the session. I don't know. We can call to order.
Okay. As you know, we've been trying to work our way through different kinds of articles in Journal Club, trying to look at different aspects of how to set up studies and also how to read the literature more critically so that you understand what these people are doing. I'm going to take the blame for the selection. So I try to go in, both of us do, and look, but it was over the holidays, so it kind of, I've taken the full blame. Really, there were only two articles in the current anesthesia literature that I thought would be interesting from both a study design side and also topical. And when I threw it around to ask people which topic, it was hands down people liked this one. Because we're always looking for the perfect anesthetic for different things, but buried in there are some really cool statistics and study design. We're going to veer off course and talk a lot about that, but this is, I think, kind of an interesting topic because I've seen people doing this quite a bit, and these guys actually, well, you'll see, jumped in and did a great job. Setting up a study with what they had, and I'll turn it over to Nate, who put the slides together and knows what he's going to say about the slides. Yeah. So we didn't send out the like assignments. If you remember, sometimes in the past and our intent is to say, okay, this group is responsible for the intro, this group is responsible for the mid. We didn't do that, so we still may throw it out for discussion or questions. We're going to try to throw softballs. so
It's group work, yeah.
So just to keep it as a discussion rather than a lecture, so we might throw a couple of softballs out to you.
Yeah, and this might be the first time you're seeing this because we didn't send it out ahead of time. Do you want to take a couple minutes just to skim it like you would normally skim a paper?
I don't know what you're insinuating.
You read the methods first. I know. It's like,
hopefully after that, everyone has a copy.
What did they do? And if they didn't do what I would hope, then I just stop reading.
I read the title and I infer what I want it to say.
Just to get a gist of it and see what's going on. I'll set a timer.
No.
Yeah, you get 4 minutes.
My reading actually slows down sometimes.
That's good. Okay. Actually, do 3 minutes now because you've had a minute.
Okay. You guys are going to have to read. We're giving everybody 4 minutes to read this, but 2 of them are up.
So Brennan's like, let me grab a cookie.
All right, there it is.
You slightly pause.
Sure. Yeah.
Yeah.
Is that where we started? All right. Okay. So you had a really long 4 minutes to read and digest the paper, make sense of it. I just want to frame it in terms of our learning objectives, how that fits into the course. So if you remember from the beginning of the year, the idea is to look at the most common types of studies that you're going to see, how to analyze them critically and think about them, and how to decide when to incorporate what they find into your practice. So just sort of like lifelong learning skills for how to stay a good anesthesiologist like 30 years after you graduate, right? Like how do you stay current beyond just talking to your colleagues and
I just
guessing.
read something yesterday that indicated that with AI, you may not have to remember any of this stuff. The AI is going to do all this and interpret for you. But for now, you have to think that you might need this in 30 years.
Right. So with that, we've got the goals for today is we're going to critically evaluate a manuscript of a retrospective cohort study, understand the basics of propensity score matching, knowing what it is, why would you do it, how it's done, and then also looking at the proportional hazards model that they used in this study, and then discuss and understand the relative advantages and disadvantages of retrospective studies. So when to use it, why would you, what's good, what's bad. And so this is the paper we're talking about. You guys all just read it. And we've got the hypothesis here.
So what they were going to look at are long-term outcomes after breast cancer surgery and whether or not it's improved in terms of cancer recurrence and mortality in patients. And/or when total intravenous is used versus inhalation. So again, we said this is retrospective, so they're going back into their medical records. We're going to talk a little bit more about this is a single, it's a big hospital. It's a national hospital in Seoul. So they have a lot. I mean, one of the advantages is that they can get the outcomes for a long time. If you do a multi-center study, you may not everybody's going to have all the outcomes that you may want. So they do it in one place. And if you look at materials and methods, so you're going to the study population, one of the first things you look at in a retrospective study, there's kind of two questions that jump into my head immediately. When? So if it's one place, it's not a snapshot in time, it's going to be a long period. It could be a long period, especially if they're trying to get thousands of people. It could be back from 1971 to the present. Turns out this is only 05 to 13. That's not that bad. You know.
So pretty current, but
That's pretty current.
With this hypothesis, so how could you test this? So we're going to talk about the way that they addressed it with the retrospective study. But if you want to know,
Thank you for jumping in.
yeah,
I'm already thinking that, but I haven't started.
yeah. So we want to know. I have a breast cancer patient. She's having surgery today. What do you do, and how do you know what to do, or do you want to study? Right? Do you? What are some ways that you can either answer this question, test it, inform your decision? Because you've got a lot of options, right?
You randomized control trial.
Okay.
Randomizing patients who are coming in for breast surgery or with history of breast cancer for surgery to either TIVA versus operational. And
Okay.
then look at data, 5, 10, whatever years down the road.
Okay.
So follow them.
Right. So you do prospective study. What are sort of the moving parts? What are some of the challenges to that, and what needs to go into that?
Crossovers, like say they have multiple surgeries, and blinding. You have to figure out how to blind it. I mean, it'd be pretty easy to blind actually, and I think it'd be easy to blind even from the surgeon. They have no idea what we're doing up there.
Right. Yeah.
So you could definitely blind it from the patient.
But you have
And
to
they're-
randomize as well, right?
Yeah.
So what happens if you randomize? I mean, it's just moving parts.
Mm.
You know, if you're going to assign somebody to one or the other, what do you need?
Some random way to do it.
Oh, a big long consent form.
Consents too. There's
You
also
gotta consent them.
so another thing with cancer, especially, they're moving towards narrower and narrower populations. If you have this weird mutation and you were born in Finland, we have the drug for you, right? So like they're starting to have good success by really narrowly defining the population. So breast cancer is a pretty broad category, and it's relevant for the retrospective study too, is like how specific do you get about who gets to be in your study? And there's two ends of that. You can have a really inclusive study, so anyone who's diagnosed with breast cancer, regardless, anything you find in that's going to be generalizable to the same people you enrolled, most likely. The other way, but you're taking a risk in that if it doesn't work, it doesn't tell you whether maybe there was a subgroup that it could have worked for. Or you can take the perfect patient in the perfect scenario as far as like this exact type of breast cancer, we know what it is, we know what happens, you randomize those, but then it's rare. It takes longer to accrue patients, and it's less generalizable. We're like, that's great if you were born in Finland, but for everyone else, this doesn't work, right? So those are sort of the two pieces that you don't know. So randomized controlled trial is one. What's another way that's relevant for today?
Yeah, I want to jump in again. What you're thinking about that is why breast cancer?
Super common.
Super common. Very good. And some of the earliest data, there was the study that they cite with that Greek guy's name at the beginning, but Sussler was the author, that showed if you did regional based anesthesia, the incidence of metastases was less. So there was like this splashy article from like 2005 that had everybody thinking that general anesthesia was bad for breast cancer. So there's like two reasons. One, it's common. That's the best one because that way you can get the numbers to actually get maybe a result. Okay.
So, right, the other type of study that we're talking about today.
And it's interesting.
Good. But there's another way to study it is a retrospective study. So what are the moving parts of that? What needs to go into it? What do you need to know? So what are you thinking about if you're going to try and answer this question looking back? What do you need?
You have to have specific selection criteria for the kind of patients that you were looking for, the kind of cases you were looking for.
What kind of anesthesia they got.
Yeah.
Even backing up one step further, you need records, right? You need to have patients that have this done.
Needs the outcomes.
Yeah.
It can't be all lost to follow up.
Mm-hmm.
Or all, yeah.
It's not there everywhere now.
Yeah, exactly. You need records, and then within those records, you need what you were saying, right? Because if everything for the anesthetic record was paper charting, and you want vitals or something, and it was based on a true story, right? And your outcome is blood pressure. That may not be so. Whatever data you have in there is what you have, and if it's squiggles and tick marks, maybe a little bit less valid. So you're sort of locked into what you already have and can access. That's the other part, is how do you get at this data? What other things do you need to know? Some places only do TIVA. They don't have scavenging systems. So in that instance, you're not going to have enough of each type of case, or maybe they found one in the closet and pulled it out and you only have 10 cases versus like 5,000 of the other. So that's sort of a non-random part that can skew what goes into your study.
Just to go back to the original breast cancer article, they had one practitioner at the institution that loved doing these paravertebral blocks. And so it was all of his anesthetics versus the rest of the departments. So what you want is roughly equal numbers, right? So you need a lot of inhalation, you need a lot of TIVAs. And so if you're going to go back and look, you can't have 3 TIVAs and all the rest inhalation. So
and then there's another way besides just for completion. How else could you study this? They mention it in the introduction. So you can try and do it in a lab. You can reduce it down to understand what's going on. You can get an animal model, which has been done. They cite a bunch of it and say it's an immune modulator. You try and guess at what you think is going on, control the system, and then try to understand what's going on in humans. But that's sort of a completely separate scenario. That's probably those studies are too early to. You wouldn't want to directly translate any of that.
no, you can't, because they're called preclinical for a reason.
Yeah. But that's the other way, is you try and break the problem apart into reducible components. But I don't even think this year we're going to spend time on that because it's not as relevant. I don't think we'll have like a preclinical.
As much as I like those, the problem with, we can study how to put an article together without doing that.
Yeah.
So we can use humans as mice. So with that in mind, you thought about this is not randomized. This spans multiple years. I'm going to get back to my point how we fill in all the really cool stuff. And so what you don't want to see is, there was a general shift in how we did this between 2005 and 2013. Did we all suddenly start to believe that this way was better than that way? And even though the anesthetic may not be important, what would change over the years? If they figured out that, if you have this kind of specific cancer from Finland, you're going to get this really great. So the treatment could be way better in 2013 than it was in 2005, because things are changing fast. So that's one of the things you want to look at.
Well, medications too. Maybe Sugamidex changed practice, or when propofol came out. If you did this study between 1965 and 1990, you're going to have a very different profile change just by availability. So that'll get into the methods. That's a good segue, I think.
Yeah, I wanted to bring that up. So, and this next slide is kind of in the results, but it's also kind of methodologic. I just wanted to touch on it kind of early. So there's 2 things here, because as soon as I saw it, it went from 2005 to 2013. I'm going, okay, what was the style of anesthesia over the time span? And did that change? And it did, but it was not in what I expected. And the second thing is that this actually appears in the first paragraph of the methods, of the results, and it refers you to the supplement. So sometimes, especially if you're curious like I was, you can find stuff that's in the supplement that's not in here because they have age and figure and table restrictions. Mm-hmm. And if they think, this isn't really that relevant, but I'm going, this is really relevant.
Some of the most important stuff is in the supplement, and usually it's things you need to see to be convinced about the flashy stuff that makes it into the main article, right?
And if you're reading it on an iPad instead of a piece of paper or in your journal, you can just cut and paste to the browser, and boom, there's your pictures. So it doesn't take any time at all, which is why I think we shouldn't be killing trees anymore. Anyway, but you see what happened here. It's really kind of cool because it speaks to that controversy that happened. Everybody switched to TiVo.
Yeah.
That big splashy article came out, and it caught on like wildfire, but it was in the middle. So kind of at the beginning, was kind of even, and there's a bunch of TIVA, and then actually it ends up with general being outnumbering a little
Is there a
bit.
shortage in there?
Maybe there was, that's another thing.
Dramatic change.
Because we all did Remy too.
Mhm.
There was a while. There's still some days we don't have Remy.
Well, cost, right?
Yeah, but
That's
this
part
is
of it.
Korea. So
Maybe they
it
know
could
it's
be
problem.
cost, and it
Probably
could
like
be
a
that.
town.
It is interesting to see how anesthesia, and if you've been around as long as I have, there's lots of fads. We get this idea in our head that if we do it this way and this way for this reason and that reason, it's going to be way better. So everybody adopts it, and then finally,
Well, and coming back to your point, a prospective randomized trial, this doesn't affect it at all because you're controlling all the parts of that. Even if everyone's caught onto the fad, you're still allocating, here's what happens to you because you said yes to this study. So that component's all taken out. But if you're doing a retrospective study, you really need to look at this to make sure it's just not random noise. If you look at everyone in that scenario and there's a non-random reason why the groups are different, it's important to put that into there. And that goes into the methods too. What could you do about that? Because in a randomized trial, you get to say who gets what. But what can you do in a retrospective study?
It's like propensity matching.
Yep. We'll go into the details of that a little more soon.
we'll let him do.
Okay, so this is your obligatory overview slide. So the moving parts we were talking about, this is what they started with and accounted for everyone and how you got into this study. So does someone want to take us through that? What's in here? What's important? What's the anatomy of this figure?
I think they're just trying to say they excluded a lot of confounding variables. Because they have a massive exclusion there. Just making sure like receiving intravenous inhalational for so many people that still do like a drug background or whatever else, it's just confounding. So it's just trying to make it as possible.
Yeah, looks like it's about 10% they lost at that first filter. Great. So you got 6,700, and then this goes back to the point of, so that's who could have been in the study, but then there's one more piece, right? That they threw that out. And that's what we talked about, like with the paper charting or whatever else. If the information's not there, you can't compare that. So just because it's missing, that can skew your data because it's probably not missing at random. So if that's not balanced well, you can get the wrong answer because of what went into it. That had nothing to do with what type of anesthetic they received. So what do we end up with after all the filtering? Get about 2,200 in one group, 3,000 in the other. So what do you think about those numbers? What are the types of questions you can answer with like 5,000 people?
I mean, you could probably answer mortality.
Yeah.
That's a huge amount. It's fairly big amount.
Yes. So when I look at an N, think of it two ways. And I think I brought this up in the first session. Depends on what you're studying. So if you go back to the parachute clinical trial example, you probably can jump out of a plane a couple times to figure out that the parachute's better, right? Maybe one in each group, just to be sure. Right? I mean, that's a massive effect. Like, you're probably not going to die to absolute certainty, right? So N of 2 is solid. Maybe even you're just like, this is not a good idea, we shouldn't do it. But on the other end, the bigger studies, you can think of it, the power is a good word for that because it allows you to see smaller changes, right? And I don't think it sounds obvious, but it's not though. It cuts both ways though. That can be a risk as well because you can get incredibly significant results that mean absolutely nothing. So the more powerful your study, the more the smaller differences you can detect. So that's why you brought up mortality. If there was a glaring problem with using inhalational agents for breast cancer surgery, we probably would have stopped, right? This also comes back to some of the neurotoxicity stuff for younger patients, right? You need large studies to look at this because for the most part, most people do okay. Same thing with breast cancer surgery. So you need a pretty well-powered study to see small differences. And that's why when I see 5,000, I'm like, okay, the changes can be pretty small in the order of a couple %, and you can still have an adequate study to answer that appropriately. So that's sort of what I'm thinking about when I see those sort of numbers. I'm like, okay, we're probably going to look at something small, non-obvious. And there's a gradient all the way down, right? So maybe a really big effect, you can do 30 or 40 in each group, to like a moderate effect, it sort of scales. So if you look at a study, look at how big it was, how big the changes are. That can tell you quite a bit about what's going on. So let's see, let's go over the methods. Now we talked about the retrospective. I think that
You get into the propensity and keep an eye, remember which was the smaller group.
yeah.
The inhalation.
Okay, so yeah, I wanted to go into this for the matching. So this is so they had a database, right? That, like we talked about. They had a way to identify people and pull out it was in there. So they reviewed all the medical records. They defined all their variables. That's what they put in the methods section. They picked a primary endpoint, so that's really important. That's where you usually power your study for. With this, they didn't do a power calculation because they said we got as much as we could. And so there's really nothing. The results sort of speak for themselves at that point because it's after the fact. And post hoc, meaning you did a power analysis of what it was, is not really considered valid. It's sort of cheating. You can do a power analysis going forward, saying what you think it will be, but going backwards, it's really not a useful statistical argument to make.
You can do a power analysis on a specific subset and then base your further study on that power analysis. Is that right?
So what do you
can choose like 100 patients and you can run everything and then you can do a power analysis on that and then base your final number on that.
Yeah. So what you're describing is where you do like a pilot study or you measure something in a subgroup, then you look at what the distribution is. So like if you took height, you'd say, all right, people are mostly between like 5 feet and 6 feet and a bit, right? So if you measure 100 people, then you get that distribution. You can guess at what it's going to be for 100,000 people and then decide and then power the study based on those differences you expect. And that's what you're talking about. But for a retrospective, right, what you have is what you have.
Yeah, and they took every available record they had.
Yeah, so it's sort of after the fact. Like there's no real power. You can say what your power was, but mostly at that point you've already done the study. Just tell us what the results are. So if you hear this thing post hoc power analysis, it's sort of not really a valid thing to do.
Yeah. It's like more like what could you have found?
Yeah, right. It's like that's not as useful.
Yeah.
But yes, for planning. So if you wanted to take this and say, okay, we want to do our prospective RCT, you take the distribution from this study and say, we know what we expect the differences to be or not be. So here's what size we would need. And,
But we know the recurrence rate.
right.
And what's a significant drop in the recurrence rate?
Yeah. Thank you. Okay, so then the statistical analysis, they went. That's no power calculation. So you get into the propensity score matching. We're talking about. So who knows something about this? Besides a little bit that I know. What is propensity matching?
What do you have on
Knows
there?
what
Put this up here.
there. Yeah.
Okay, it's a good start. So what does it mean? So I put how to do that. This is Cliff Notes version of Wikipedia. one of the confusing parts of statistical language is they make it so abstract as to be inclusive, but I find it gets really confusing. So probability, though, that's an accessible word, right? That's your chance of something, right? So this is the idea that if you back it up a little bit, how did you get into that group? And we've talked about that a little bit. Did you get there because we only do TIVA at this institution? Right, so if we can make it specific, it can help the concept be a little more understandable. So in our scenario, someone being assigned is being assigned to either TIVA or general anesthesia. So if you think about that, the propensity score then is what goes into whether you got TIVA or you got inhalation, right? So if you think about that in the specific realm, it's, well, if you have a bunch of nausea, maybe you get TIVA, right? How do you make that decision? So the things that go into your risk for PONV would be, right, like female gender, younger, history of PONV. So if you flip it that way, those are the sort of things you want to know to make sure that you can match on that, right? So someone who is a young female with a history of post-op nausea and vomiting, you want someone who looks exactly like that but got inhalation instead, right? So if you think about it that way, what are the things you need to know to make sure that they're matched and that the reason they got in the group was either random or at least the same? I think that's a way to maybe understand matching. Dan, you're nodding your head. Could you explain that back to make sure that it makes sense, or is there another way?
In my head, it was just kind of like, just make sure everybody's kind of the same, that they still have the same risk factors. You're saying, like, I mean, you picked nausea. I'm trying to think of it better. So I don't know why else you would do a TIVA besides PONV, or like malignant hyperthermia.
Yeah.
But no one's ever going to run inhalational with malignant hyperthermia. But that would be like,
Right. If you're trying to
something
study
like that.
Yeah. And you brought up a good one before. The original study was someone liked to do paravertebral blocks. Maybe that provider only works on Tuesdays. So something else that would be non-random is like day of the week, right? Because if, let's say Wednesday you're not getting a paravertebral. You happen to be scheduled for Tuesday, you do. Right? So that would have to go into your propensity matching. Anything that makes it non-random for you to get into either group is important to understand. And some of this is based on logistic regression. And the way, do you guys know about logistic regression? We've talked about it a little bit here. I want to try and make it as easy as possible, but the regression part is a line, right? So if you say put a variable on X or a variable on Y, put all your data on there and try and draw a line that is closest between everything. So if you have a scatter plot, you make sure that the line is as close as possible to all of them, and then what that's capturing is how do these two variables relate to each other. It's a really powerful technique. You can point at a lot of different things, and you can put in a lot of different variables to see how it moves that line. But that's what logistic regression is based on, and that's really gets back to that question that we're talking about. And the way you test whether a variable has anything to do with it is you put it in, and if the line doesn't move, it didn't do anything. Right, so that's what you're doing with this when you run propensity score matching. You say, is it a Wednesday? Is it a Tuesday? Is there a paravertebral block? Does the line move? If the line doesn't move, you don't need it in your matching, right? Like male and female gender wasn't important. They excluded some of them. Maybe that would move the line, and then you need to account for it. So that when you make your two groups, everything that mattered and actually moved that line gets into the matching. Because otherwise, what's the flip side of that? What's something that?
Yeah, and the other way I look at it as well is when things turn out different, and there might be a reason that nobody is talking about. So you try to think of every possible reason. But I thought this was going to have a lot of blood loss, so I didn't want to give it TIVA. I looked at the patient and said, this isn't the fit. So you're going to look at blood loss, right? This would be you're going to put that in there. So you're gonna look at all the things, you're gonna look at body weight, you're gonna look at ASA stat, anything that might be part of the selection process between the two, you try to bring that into your propensity matching. There still could be something you don't factor you're not thinking about, like the Tuesday thing.
Right, that's the problem I wanted to bring up. Like, what's the big issue with this? There could be too many variables, but an even bigger problem.
Irrational people.
Right. Things you don't know and can't know. Right? Like, you don't know Sessler's schedule, right? For the paravertebral study as an example. Like, if you don't know the day of the week, you could have a completely wrong study just because there was something you don't know that's having a massive impact on your data that you can't measure, like provider schedule or something.
Provider schedule, I mean, this, chemo schedule over the weekend is different.
Sure, yeah, for like dialysis, like why is weekend dialysis? These other things that don't go into it.
Yeah.
So you try and be as thoughtful as you can, but that's how this thing can break, is if there's something you don't know that's has more to do with your data than what you're measuring. But for the most part, I would say it generally works within, depending on what it is, if you have enough that you can put in and measure. So those are the parts that you want to look out for. So that's propensity matching. As the limit, with my limited understanding, and probably what you need for this study and other ones to evaluate them. What about proportional hazards? Anyone know anything about that? What are we even talking about? So again, with the stats language, I like to start with things I know and are understandable. So proportion, right? That's just a fraction. It's comparison. How many of this versus how many of that? And a hazard, it's got to have something to do with risk or danger or something else, right?
Bad stuff.
Bad.
The bad
It's not
stuff is
good.
recurrence, it's bad.
Yeah.
So the hazard in this case is cancer recurrence.
Yeah. And what this is really looking at, the key point here for the proportional hazard model is that there's a rate of bad things happening. So they use this for controlling manufacturing processes, for example, like your car has a lifespan on it, and that's going to be different for different cars, but they know if you buy this type of car, it'll typically go this many miles, provided you don't crash into a tree or something, right? So you need to know a baseline rate of something bad happening, whatever that is. So again, for the stats part, it's easier to understand in the specifics. So what are we talking about for this study? What's our time to event we care about? It's recurrence, right? So recurrence is going to happen. If you're diagnosed with cancer, there's going to be some sort of recurrence that's going to happen with some rate. So what would this model help you out with the question in this study? What are you comparing? What's your proportion? Because you need two rates, right, to compare. What are the moving parts? Does it move that line, right? Does it change your event rate over time?
Is it one or is it something else?
Yeah. Does it not, or does it do something to
it's
it?
One, your proportion is one.
Yeah, they're equal. So that's what the proportional hazard model is. It's taking two groups, comparing that rate, and seeing if anything moves that in either direction or not. Yep. Does that make sense? Those are kind of the two big, I felt, sort of more confusing parts of this study, and just trying to simplify them and understand what they did and what goes into it. I think that's anything else from the methods that is important?
No, other than one of the things they did, it's actually they had a secondary, if you look at one of the first things I look at in every article is the last paragraph, the intro, because they're supposed to put in what they're looking at. And they did put in that they were going to look at other things from the record that may increase the risk of recurrence. And I looked at that as, okay, they're going to see if this data fits other models. Like if you have a bad genetic phenotype or genotype, your recurrence rate ought to be really high, and that hazard ratio ought to be bad. And so that means they're measuring that. So where does anesthesia stack up versus those things? And did our methodology capture those the way it was supposed to?
Yeah, it sounds like a positive control,
It's like
right?
a positive control.
Right, like you know the cancer subtype for, which is why they measured it, or the other one that came out, and we'll talk about in a little bit, is age, right? So if you have cancer when you're older, they have like higher recurrence. And if you don't see that, you have to question your methods and say, well, we know this is a problem and it didn't show up, so we're missing something. But, we'll get into the results, but like I said, they were able to detect that some of the subtypes were worse. So if you don't see it with anesthesia, or you do, then you can be a little more confident that the method that what you've built is working, right? Like your study's doing what it's supposed to do. What's going on? It's table 1. What are they showing us here? Why is it? What's in there? What's important about it?
Just comparing baseline characteristics for each group to show that they're not significant.
Mm-hmm.
We're trying. I didn't even look at them.
So some of the pieces are significant, though, right?
How much 70% of these patients is?
That's a good question. That's a good.
70% of this study
Probably
patients
it's
ASA1.
Oh, lots of places, so it's a style thing. So, yeah, we tend to call people with cancer ASA2. We tend to call people who are perfectly healthy and pregnant as disease, that they have a disease called pregnancy.
It is.
But most places, if you look at most places, if you look at most studies that pop up for ASA1s in delivery or OB studies, 90% are ASA1. And we would say that's impossible, but that's a style difference. So you have to understand that in different places, they have different rules. If you are otherwise healthy and you have a cancer, then you're an ASA1. Yeah.
Seems like just poorly controlled.
I mean, when the ASA recommendations are social health too, right off the bat. Maybe not in pregnancy, but.
That's important for generalizability. If ASA status is one of the things you want to match on, you've got a Korean study and an American study. That's one of those things that needs to go into your just.
Well, it's which institution? It's institution by institution.
Yeah, so that's important to
I
know.
was at an institution that thought it was anathema to call a healthy pregnant lady the ASA2. She does not have a disease. This is part of life.
However, if she were to die in the next 5 minutes, it would probably be related to the non-disease.
True. Right, so it's comparing those two. And I think of this as looking at what happened, who got included into the propensity match cohort to see what it's doing. And just sort of, these are the things they felt were important that go into their matching. So those things you need to know about these patients to understand whether they were well matched, whether you're comparing, you want to make sure you're comparing two similar groups. And these are the things they felt were important and that they tested. I believe the next few, so the next part is showing you the overall results. If you only got one figure, this would probably be the one to look at. Did you want to say something about that?
No. I was going to editorialize, but totally different, off the subject.
Okay, all right. So what's going on in this one? What are these graphs? We got a red line, a green line, got numbers at the bottom. What are we looking at?
They're the Kaplan-Meier curves for our two endpoints.
Okay. What does it tell us? What's on each axis, and what can you figure out really quickly?
So one is all of the patients are alive, and then as it goes down, you have or alive or have no recurrence. And so then as it goes down, those who have people dying in that subset of population, or people having recurrence disease. And so it's showing that they're basically following along the same line and the same pattern. And so just grossly looking at it, there's not much of a difference between the two groups.
Mm-hmm. So that's our big question, right? That's why I said if you only have one figure, this is it. If something's going on, it's incredibly subtle and not picked up by this study. Right. Because you can imagine if you had something massive, it would go like this. You've got a nice green line, that's your, if inhalation was way better, and then red line would go like this or something. Right? So the further apart those are, would be a bigger effect size.
I think it's remarkable that they're all alive. Over 11 years.
Most of them, some, not all.
Are they not all alive?
No, 90%.
Oh, I see. Okay. I thought you said they were all alive.
At one.
That one.
Oh, at one. I thought you meant
This would be if it was straight across.
Yeah.
They're all the innocent ones.
I was like, this is the best breast cancer possible in the world.
No, okay, yeah, I misunderstood.
That's a good point, though. If you're looking at mortality or recurrence, they've had a reasonable amount of success in treating and managing breast cancer, right? So going back to study design, maybe this wasn't the best cancer to study for this. It is common, but thankfully it's also very treatable, and patients do pretty well compared to, like stage 4 melanoma or something, or pancreatic cancer. This would be a very different curve. Okay. Another long table. What's different between table 2 and table 1? What is this showing us that we didn't already see? Seems a little redundant, right? What are they trying to prove? Because it took up a lot of space in the limited journal pages.
I mean, this is your outcome. It's like your recurrence-free survival. You're talking about what's the difference between this table and this table?
Yeah, so what
This is just the population study, and this is telling you actually the difference between your two treatments.
On that piano has a hazard ratio.
and this is
Yeah, it's your hazard ratio. Whether something bad's gonna happen or not.
right. This is also showing you what their matching is doing, right? So they want to prove you, like, okay, if we didn't do any matching, what would this study show you? And I think that's another way of pointing out that we needed to match for all those things that we talked about. What goes into whether you got a TIVA or inhalational, or whether you recurred or not? What's important to know? So it shows that when you match, you're actually improving the study and making it more valid. Because otherwise, why bother? Because there's a lot of opportunity you're changing the results of the study. And you're saying we were justified in doing that because we're doing it for a good reason. So what are the things that changed when they adjusted? Why couldn't you just do an unadjusted study, say? Everyone we saw in the group, what would be wrong about that? Because it's in this table. That's what they're showing you. What would be wrong? What's your clue? How do you even tell?
Confidence intervals.
So age matters.
Yeah, what matters? What changes? Exactly, all that stuff we were talking about, right? If you've got a worse cancer, that's important to know because your recurrence is going to be different. That's going to be bigger than probably your anesthetic. Otherwise, we'd be causing cancers. I don't know, like that wouldn't make any sense, right? And so it's just showing that if they can take something that was significant in the unadjusted and make it not different between the groups, now your matching is working. That tool you built is doing what it's designed to do, which is to make the groups more similar so you can compare, to answer the question that we set out to answer, is that should you do a TIVA versus inhalation? But you have to make sure it's working before you can say that this study adds to that. And that's what this table's about. All right, what else do they have for us? Yet another table. What is going on? I thought one was pretty good, right? Like what?
Just looking at different measures.
What else could they possibly have to tabulate for us?
They're just looking at the death outcome rather than the recurrence outcome.
Yeah. Because when you put it together, right, the Kaplan-Meier is great because you care about both those things. Recurrence is bad, death is bad. And you get a lot of information right away. But you want to break it out, right? Because those are pretty different. Because you could then treat it again and then sort of different outcome. But important to see. So same thing. You want to prove that your tool is working for both of these main outcome variables when you break them out. Okay. So if you weren't convinced before, what is this? This is in the supplemental. I actually like this one way better than the 80 lines of tables. But it's showing you the same thing. So you got some color coding now though, and it's graphical. And this comes back to the way that they checked how well their matching was working. So there's maybe 6 or 7 different ways you can decide how close your matching is. You can either look at like the standard deviation for how close they are. There's this caliper method. There's a few other things. But the one that they chose, they're trying to show you that before the green dots, you've got a big difference between the groups. And then by doing their matching, you get red dots. So this is a smaller difference between the groups. And by matching, they were able to move everything to the left, make it less
the one
difference.
with the green dot way over, we already saw in that
Bar graph.
the bar graph. It was like, yeah, it was highly popular.
Fad. So you have to account for how trendy the current treatment is. So that was important that they looked at that. So that's what that's showing. All right. So what are you guys going to do? We got the whole schedule for tomorrow is breast cancer patients, and we're going to do mastectomies. What are we going to do? TIVA, inhalational? Paravertebrals for everyone. Flip a coin. What do you think?
Dealer's
What did-
choice.
Yeah.
Doesn't sound like there's necessarily any convincing evidence.
Just make my decision based on
Except I
other
still
things that influence
personally
that
believe in TIVAs.
Yeah, I mean, I thought it was interesting, like the BMI is all 23, that was their average BMI.
Welcome to Korea.
Korea.
So you wonder how like body, that inflammation
Bad
and
place to
all of
study
that,
Yeah.
Bad place to study.
influence the recurrence. So I don't know if that makes any difference
It could.
to us.
Yeah.
It's good. I'm glad you're thinking about that.
Yeah,
Now you're
that's great.
seeing what goes into it.
Yeah.
So do you think this study helped make that decision? Did you have a different idea? Because before I read this, I was pretty sure TIVA was where it was at.
Yeah.
I guess I'm sort of late to the fad, but do you think this adds to what's known about it? So the introduction and the discussion where they in that second minute you had to read the paper, they go into sort of what's been done, what led people to think that this is a reasonable thing to even be studying or looking at. And a lot of what they said is all the available studies are pretty small.
I don't know.
That comes back to the power. Like I thought this was a pretty well-powered study. I thought they would have, if there was a difference, I thought they would have been able to pick it up. A difference I care about, anyways. This probably would have shown it within that.
It's one center in Korea.
Sure. But it's
I think
still.
it's kind of muddy being retrospective study. I mean, I don't think you can make a lot of conclusion about it. Like, one thing here is the opioid administration. That was statistically significant between the two groups. 100% of the TIVA group got opioids and only half of the inhalation group. And I think they're showing that there's opioid receptors on cancer cells. So there could be like a hidden, confounder that we don't necessarily know that could have influenced it and made it look even retrospectively. But I think to make a conclusion, you would have to do a randomized control and control for that type of thing. Everyone gets the same amount of opioid. You run a REMI in the background regardless of whether you use propofol or inhalation.
And that would help answer that too. And I think they say there are RCTs going on. So when should you even bother? Was it worth doing this study? You think it helps while we're waiting for the?
Comes up with questions and like ways that you could design a randomized control, like it identifies all the different things that are a part of it.
Because I would argue this is the best available evidence. I would say this trumps a smaller RCT if there are one. Maybe someone did 30 in each group. And even whether they saw something or different or didn't, I would still say this is better data. Why?
The power.
Just to play devil's advocate, I keep hearing Flores's like voice in the back of my head. Is everyone getting that? Flores, yeah. He makes the argument. I guess there was some in vitro data or something that shows that volatiles are they negatively affect natural killer cells, and that's really significant because it's mainly kind of checked by natural killer cells. So his argument is, even though we don't have a randomized controlled trial yet that shows a difference, and some of the studies are kind of like plus minus, it's such a big thing. Cancer is such a big thing, and recurrence of cancer is such a horrible thing to have happen to you. So really, like, put you out with all that much to set up the T and set gas. So
I'm going to throw, so for somebody trained and lived their whole life in clinical pharmacology, what percent of studies that had awesome preclinical trials failed in phase 2?
99.
90%
Or more.
or more die because they cannot, which is absolutely 100% true in the lab. When you put it in real life, doesn't matter, it doesn't translate.
I guess in this case, though, since we don't have a randomized controlled trial,
Right, so
and
that's why
the difference between the two like interventions, like the difference between like setup time in the morning, really, is like and cost. But I think even TVIS is becoming less expensive than it was.
Right.
So
Yeah, it's a good point. So when do you do a retrospective study?
get funding for a randomized.
No. I mean, yes, but no. When you have to, for one thing, right? Parachute. Like, people who fall out of airplanes are fine. Pushing them out is not okay, right? Like, and that's a retrospective study. Are the results valid? Yes. Still same conclusion. Still right.
Certain populations are
Yeah, like the thalidomide thing, right? So that's another one. So when it's unethical, or when it's crazy rare, right? If you're like, like the obese Korean person or something, and mold and something, you're not going to be able to do that study because it's not feasible. But if you put a bunch of centers together, and you can do it retrospectively, potentially. So it's not possible, not ethical. If the data is available, probably a reason to. Cost. What are some other reasons to? Yeah, I'm trying to think. When is a retrospective study better than a prospective study? I think we brought it up a little bit.
big groups, like 2 people.
Yeah, power. Especially when it's well matched. Okay, let's see, what else we got? I think we talked about some of the limitations and benefits. Any other final thoughts on this? So I hope one of the things you get out of it is that retrospective studies can be valid and very powerful, and don't just throw it out and say there's no randomized trials on anything. That even if there are randomized trials, I would challenge you to say, how good are they? What population, and is it really compelling, right? So just saying it's the gold standard, prospective, double-blind, placebo-controlled, that doesn't mean you should do it. And then conversely, if they only have a bunch of really well-designed retrospective studies, don't discount that either for the same reason. It may be valid, and could be more informative and better powered. So don't be too prejudiced. Actually, it's still worth reading the papers and trying to figure out what's going on, and drawing a lot of different types of studies.
The other thing about the ones that tend to be well done like this are there'll be an editorial. And if you're really lucky and you're really interested, I'm not saying go do it, but there'll be a podcast with the editorial writer and the lead author or the senior author of this group. And those are about 15 minutes long. And it can do questions back and forth. So yeah, but I would encourage you anytime you're interested, like if this interests you as a topic, go read the editorial. It'll give you more background and say things like what you brought up. Maybe is like what about obesity? I mean that's a whole other area that
It's a major risk factor for breast cancer too,
Right.
right? Yeah. So, all right.
okay.
Thank you. Yeah.
Okay.